CME event endorsed by the Emirates Cardiac Society and also by the World Heart Federation and kindly sponsored by Asino Pharma. We are talking about best practice of lipid management in the Gulf Cooperative Council. We have two excellent speakers tonight. Each one will give a presentation and then we will have a discussion at the end. Our first speaker tonight is Dr. Nushin Bazargani, who needs no introduction. She is a consultant cardiologist at Dubai Hospital. She is the vice president of the World Heart Federation, and she is the leader of the preventative working group in the Emirates Cardiac Society. Dr. Nushin will talk about lipid management in problems in the GCC. Welcome, Dr. Nushin.
Thank you very much, Dr. Wild, for kind introduction. You all agree with me that we are living in very extraordinary timing in an age of globalization and growing insecurity. Health, more than any time, has become everybody's business. And with the impact of global transportation and communication network, a tiny virus like COVID-19 in China can be transferred rapidly to the globe. In an interconnected and interdependent world, bacteria, viruses can travel almost as fast as email and messages. And of course, with all of that, money flows. But despite of all of these facts, still cardiovascular disease is the leading cause of mortality and morbidity worldwide and in our region. But because the communicable disease like pandemic COVID-19 has both major economic and political burden, we hear more about communicable disease usually than non-communicable disease and cardiovascular disease, which has mainly major economic burden. So cardiovascular disease has many contributing factors that if you only concentrate on the treating the patient at this stage, we will not gain anything. So it is actually the social determinant and drivers with the globalization, urbanization, aging, income, education, the type of houses that will translate into behavior risk factors like unhealthy diet, tobacco use, physical inactivity, harmful use of alcohol, which will produce the major cardiovascular and metabolic risk. That will result in the producing cardiovascular disease like MI, stroke, heart failure, and kidney disease itself. Now, this slide is very old. Maybe it was produced at the time that's most of you maybe were very young. And very, very early, we identified all the risk factors for ischemic heart disease, which is showing in this slide. And later on, we managed to classify them into modifiable and non-modifiable risk factors. But experience and evidence taught us that our theory was wrong. And indeed, most of the risk factors for cardiovascular disease are preventable. And only very tiny numbers of these risk factors are not preventable. And all of these risk factors are amendable to control by measures that are already available, and they have already proven to be effective. The other phase of presence of these risk factors is that a single person or a single individual most of the time has multiple risk factors clustered in one. And that's not only help in the production or producing cardiovascular. Other impact that income has shown that all of these risk factors that usually cluster in one patient, they have additive effect on each other. So 1 + 1 for risk factor of cardiovascular disease does not equal 2, but it ends up by having huge burden of risk factors on the individual patient. Just like pandemic COVID-19, the treatment of pandemic COVID-19 is not to treat the acute cases. The treatment and the proper management is prevention. And the same thing goes for the cardiovascular epidemic that we are all facing. And the solution is definitely not at the tertiary hospital with devices and a stent and interventions. And indeed, there are multiple varieties of the management for the control of these factors available in clinical medicine, but unfortunately, there are a lot of barriers into the implementation of these guidelines. And if you take, for example, the barriers toward the physician centers part, we could enumerate that some of our physicians are still unfamiliar with the proper and updated guidelines. There is confusion between European, American, Canadian guidelines, the complexity of the different guidelines, and also the treatment that you offer your patients also can act as a barrier. There is a lack and difficulty in flow of the follow-up of the patients when we start them on treatment. And there is a failure to regularly educate patients and population in general. This slide is taken from World Heart Organization, and you can see that the management and the guidelines of the non-communicable disease, including diabetes, cancer, chronic respiratory disease, and cardiovascular disease, although it is available in most of countries, but it is not fully implemented. And you can see that the lack of implementation of these guidelines is almost universal for all the diseases under non-communicable disease. And on the other hand, it varies between different countries according to their financial and economic state. And you see here that the percentage of the cardiovascular disease patients who do not receive any medications, how high it is in low-income countries compared to the higher income and other countries. Now, even if we have the money, even financially, if the government is okay, just simply prescription of the medicine is not guaranteed for the result. So there are still a lot to be done other than prescription of the medicine. And there is where the education and the prevention comes into hand to hand. I like this slide because we actually managed to be shifted from the treatment to the prevention. And always we face the same argument between the healthcare professionals and over primary healthcare professionals. But one could argue that both prevention and healthcare are complementary to each other. Prevention alone loses credibility of the health system if the health system does not have and provide efficient and timely care for acute cases of, for example, cardiovascular disease. And the clinical care alone will not stem the tide of cardiovascular disease, and even the benefits of good care are lost without further prevention. And we see this in clinical practice. So for a good cardiovascular disease management, we need a strong primary healthcare system and tertiary system. UAE is no exceptional to the rest of the world, and this survey was carried out by Ministry of Health in 2018, and they tried to identify the major risk factors for non-communicable disease, including cardiovascular disease. And you can see that from overpopulation in United Arab Emirates, overweight, physical inactivity, and hypercholesterolemia was the three top major risk factors for development of non-communicable disease, cardiovascular disease, diabetes, cancer, and chronic respiratory disease. And unfortunately, dealing with this high-risk population has translated into a high mortality of overpopulation, especially young age population, from cardiovascular disease and cancer. And you can see, compared to other countries, we have the higher among the highest numbers of mortality. Now, I have been asked to present to you some local data. So I have chosen two of the studies which was done at two different scenarios, one at the community primary prevention, and second one is the hospital-based data. So I'm going to talk to you about case study, which was actually led by Dr. Alawi and his team. This was a prevalence of the cardiovascular risk factor in patients attending general practice clinics in Africa and Middle East. It was a cross-sectional, multi-center, multi-country study. Every fifth patient who were attending a GP practice was enrolled, and approximately 20% rural population were 20% of population were from rural area, and they managed to get about 4,300 patients. The inclusion criteria was any male or female above age of 18 who had signed a consent, and of course they excluded pregnant ladies and whoever had life-threatening condition. The primary endpoint was the percentage of subjects with obesity, abdominal obesity, smoking, dyslipidemia, diabetes, and hypertension. And they wanted to compare the prevalence of these risk factors between urban and the rural population. And on the other arm, they wanted to compare between male and female population. So obesity was defined as BMI more than 30. Abdominal obesity was defined between the waist circumference between 80 to 94. The smoking was defined as current or past consumption of cigarette pipe or water pipe. Diabetes was defined as plasma glucose more than 7 millimole, and hypertension at that time was defined as BP more than 140/90. Dyslipidemia was defined as if the patient had one of the following criteria, if the patient had 0 to 1 risk factor and LDL was above 160, for patients who had more than 2 risk factors, the LDL was targeted more than 130, and the subject at high risk or with cardiovascular disease and diabetes, the LDL was more than 100, total cholesterol more than 240, HDL less than 40, and triglyceride more than 200. So these were definition of hypercholesterolemia or hyperlipidemia for this population. So the summary of the study, they aim at evaluating the prevalence of the cardiovascular risk factors, mainly obesity, smoking, diabetes, hypertension, and hyperlipidemia in a primary care setting. This was a multi-country, multi-center study. They recruited more than 4,300 patients in 6 countries. 2 countries in North Africa, 6 countries in Africa, and total of 14 countries, and 6 in Middle East as well. These are the name of the countries in Africa, and these are the name of countries in Middle East. And you can see that UAE, Egypt, Saudi, and Kuwait, and Lebanon, and Jordan were included among the 6 countries in the Middle East. This slide is showing to you the demographic pattern of the patients. You can see that we had good representation from both male and female. The mean age was 47 for male and 46 for female. The BMI for male was 28 and female was 30. Now, overall result is summarized in this slide, and you can see that, again, abdominal obesity and dyslipidemia were the top most common risk factors that was identified in this population, followed by hypertension, obesity, and diabetes. Now, the difference between urban and the rural population is illustrated in this slide. And obviously, you can see that when it comes to the urban population, they have more risk factors compared to rural. Overall, female population had more abdominal obesity, and dyslipidemia was slightly higher in male population. Smoking was more in male population, but we all know that females usually don't like to report if they smoke any kind of tobacco. So the conclusion for this brilliant study by Dr. Alabi and his team was that the population that they studied were young population. Although they were young population, but they had a lot of risk factors. So population was overall overweight. The high prevalence of dyslipidemia and abdominal obesity, almost 70%. And imagine, the mean age was 46. The prevalence of hypertension was 45%. And there were high prevalence of obesity and overweight subject, 35% in each category. So they concluded that the prevalence of dyslipidemia, abdominal obesity, and hypertension is higher in urban region, and prevalence of obesity and abdominal obesity was noticed to be higher in women as well. So I would like to shift now to a hospital-based registry. This registry was done by my colleague, Dr. Sadiq, in Dubai Hospital. The name of the objective of this registry was to analyze the use of intensive lipid lowering therapy at discharge in a broad population of patients who were admitted with the diagnosis of acute coronary syndrome. And the background and the rationale for this registry was that several large studies have consistently demonstrated that lipid-lowering therapy with statin reduce cardiovascular risk irrespective of underlying coronary artery disease. And even in patient with a stable coronary artery disease, as well as acute coronary syndrome, statin therapy has shown a reduction in mortality and recurrent cardiac event. So all patients with the diagnosis of the acute coronary syndrome were enrolled. We had in 5 months about 282 patients, and the use of intensive lipid-lowering therapy and less intensive lower lipid therapy at discharge were assessed. The baseline characteristic of the patients and all the demographic data was recorded. The lipid-lowering therapy, the intensive lipid-lowering therapy, which was used, was defined as a therapy that can achieve more than 50% reduction in the LDL in lipid-lowering therapy, and included atorvastatin 40 or 80, rosuvastatin 20 or 40, simvastatin 80, or any statin of any dose used in combination with ezetimibe. Now, you can see that the mean age of patients was 55, with the median range was 54. We had more male patients admitted during those 5 months. Patients mainly admitted with STEMI, and lipid profile at the admission time was carried out, recorded for most of the patients, but unfortunately, the follow-up lipid profile was missed for most of the patients. So at discharge, most of the patients, they had a high dose of atorvastatin, and then it followed with the other statins and the other lipid-lowering therapy that you can see in this slide. Now, the baseline of the cholesterol for these patients, of 249 patients, the mean value was 194, and the median was 184. And then at the follow-up, and you can see it on the right-hand side of the slide, the follow-up, we managed to, of the total of 42 that we had follow-up, we managed to decrease their cholesterol from 194 to 130. As you can see, we had a lot of losing patients in follow-up for different reasons. One is the patients financially cannot come follow-up. Number 2, the patient's insurance is covered by other hospital. Number 3, some of these patients were not resident of UAE and had to travel back home, or they were residents of UAE and they go back home for further management and intervention or heart surgery. Now, when it comes to HDL, the mean value was 40, median was 38, and you can see that again, we had a slight actually reduction in the HDL because patients were on a statin, and we can see a slight reduction of the HDL in this population. The LDL baseline was, the mean value was 118, the median was 114, and of the 41 patients that had follow-up, their LDL had increased to 63 mean and 63 median. The triglyceride is the same. The mean was 180 and median was 150. The conclusion of this registry was reported as that the lipid profile was assessed in the majority of patients during hospitalization for acute coronary syndrome. Majority of patients were discharged with the intensive lipid-lowering treatment. The other lipid-lowering treatment was used in the minority of the patients. But unfortunately, minority of patients had a follow-up lipid profile. But the one who had a follow-up, it showed a significant improvement in the lipid profile. Excuse me. So, ladies and gentlemen, the best way to treat these patients is not the one that I'm supposed to talk about. That is the part that Dr. Hani will talk to you about. My role was that to show you the problem that we face in the preventing, detecting, treating, and controlling high cholesterol, because globally, raised total cholesterol more than 5 millimole per liter affects approximately 39% of the adult population, 37% for men, and 40% for women globally. And the GBD study in 2019 reported that according to GBD study, the leading risk for mortality in 1990, if you can see it, the high LDL was very much down, number 14, but in 2009 it has gone up to be number 8. So this risk factors is actually speeding up and is getting stronger in the pathophysiology of cardiovascular disease. And again, as I mentioned, like any other cardiovascular disease, and the cardiovascular risk factors, hypertension, diabetes, metabolic syndrome, and dyslipidemia are risk factors that need a different level of management and prevention. We should aim at primordial prevention, primary prevention, and finally secondary and tertiary prevention. And that is the message from World Heart Day on 29th of September, which is operate. We should, when it comes to cardiovascular disease, we should concentrate on inform, prevent, detect, treat, and measures, and each one of them actually is assigned to individuals, to the health professionals, and to the community health system. So each individual has his own objective in all of these 5 measures. From the health professionals, us, we should definitely inform our patients and discuss with them lifestyle as a standard of care. We should prescribe a specific diet and exercise and medications to prevent. We should always assess the patient's risk factors. We should always aim at treating these factors, and we should always measure our performance in the form of track patients parameter or participation in the national registries. In the community and health system basis, meeting all of these criteria of information, prevention, detection, treating, and measures is somehow more complicated, but there are countries that have actually succeeded in proper community and health system-based prevention of risk factors for cardiovascular disease. Now, in conclusion, ladies and gentlemen, cardiovascular disease is still the top killer. A lot of improvement can still be made. Hypertension, diabetes, tobacco, dyslipidemia, and abdominal obesity are risk factors for cardiovascular disease and death. We should have a better screening and awareness and optimizing of the treatment of these risk factors at early stage through primary prevention, and we should have optimized treatment at the time of event and after the event at the setting of the secondary and tertiary prevention. And with that, I would like to thank you for your attention.
Thank you very much, Dr. Nosheen, for that elegant presentation. Please put your questions on the chat. Our next speaker is Dr. Hani Sabbour, who also requires no introduction. Dr. Hani is a consultant cardiologist at the Heart and Vascular Institute at Cleveland Clinic. He carries a lot of hats, and he is an expert in lipidology, electrophysiology, and heart failure. And today he will tell us his expertise in lipidology and talk about lipid management, best practice, tips, and tactics. Dr. Hani.
Thank you very much, Dr. Weil, and thank you, Dr. Nosheen, for the outstanding lecture and setting the stage as how really, really important it is to address this one of the most easily modifiable risk factors in the modern world. So we will try to tackle some tips, tools, and tactics, and share some of the insights. So this was very nicely covered by Dr. Nosheen. Just to highlight one important point, that cardiovascular disease mortality is the #1 cause of death in the UAE and is increasing rapidly. It's accounting for about 37%. It's increasing rapidly by 23% in the last 10 years, has caused more than 50% more deaths than cancer, and actually causes us to have the second highest mortality rate after Saudi Arabia, which Dr. Nosheen showed from the Ministry of Health and Prevention model. It also means that this cardiovascular disease is the primary driver of cost in the healthcare system, and as was very, very outstandingly pointed out, why not start with primary prevention and primordial prevention at the early stages instead of having the patients develop a complication? So I'm going to try to answer 12 important clinical questions. I tried to make them 10, but they became 12, so I apologize for that. So we're going to look at patient assessment and risk calculators. Does your patient know their numbers, the targets, and goals? We're going to discuss risk enhancers and risk calculators, and we're going to look at something very important. What are the best risk calculators we can use in the Middle East? And I'm going to refer to a very important paper that was published actually by Dr. Weil and his group a couple of years ago, and which population the risk calculators are validated. Now, the next point is treatment, and are we using and dosing statins correctly? And I'd like to call this the right dose for the right risk reduction, because it's not just about putting the patient on a statin, you have to achieve a certain number. And are we getting the maximum benefit of the currently available statins? The next clinical point, which we see, and I think Dr. Nosheen pointed this out, are we escalating to the maximum tolerated dose? And when is maximal doses needed? And of course, part of that is remeasuring your lipid profile after discharge to see if there's a response or non-compliance. What is the role of ezetimibe as a monotherapy? And what about combination lipid lowering therapy? And do we have to consider separate medications or fixed dose? And then some advances like the PCSK9 monoclonal antibodies and the even newer PCSK9 sRNA. And also, I think this question comes up a lot. Which lipid lowering guidelines should we use? The ESC, EAS guidelines, the American guidelines, NLA guidelines. Do we have Middle Eastern guidelines? And the answer is yes, we do, and I will show you that information. And finally, from a practical standpoint, how to close the gap between guidelines and current practice. So it's a lot of points to cover, and hopefully we'll be able to get it done. So this is a core and a very important point for everybody to remember. Over the last 20 years, randomized clinical studies, almost 49 clinical studies, and updated even more recently with 52 clinical studies. And look at the number of patients that were enrolled in the statin therapies, 170,000 patients, 312,000 assessing multiple therapies, and this is a meta-analysis of 327,000 patients, including statin, ezetimibe, and PCSK9. If you average all of this, a 1 millimole, 39 milligram per deciliter reduction of LDL is linear and proportionately reduced 20% of cardiovascular events. And it didn't matter if it was done with statins, ezetimibe, PCSK9, combination therapies, it's a linear relationship. So it's approximately 20% reduction in major vascular events, 22% reduction in mortality, CHD, and 10% reduction in all-cause mortality. So this is very important because really, as Dr. Nosheen mentioned, we want to prevent the first vascular event. And if you don't lower the LDL sufficiently, you still have 20% extra cardiovascular events that you could have prevented, which is very sad. And this is sort of a graphical presentation of the first meta-analysis from 2012. And it's really clear. Even in the low-risk patients, these are patients who have an annual risk of less than 5%, look here, you still have with statins from 2.7 to 1.2, that's 50%. In the higher risk or moderate risk patients, it goes from 8% to 4%, and this is actually over 5 years. In the highest risk patients, which are the ones you want to absolutely put on the maximum intensity and lower their LDL greatly, look at this, 30% risk, 46% goes down to 20%. It's still not normal, okay? And this presumes a drop of the LDL by 2.5 millimoles, so almost double of what is being achieved in outside clinical practice. And similarly, if you take the definition of major vascular events, so it's 50%, 50%, 50%. It's a linear relationship. So clearly, if we underdose the statin and we don't give enough lipid lowering, we're never going to get that 50%. And this is reduction not of cholesterol, reduction of vascular events. So the recent updates of the guidelines have come very close to each other. 2018 ACC-AHA and the ESC actually published within about 9 months of each other. The new evidence that came from multiple clinical studies, including high-intensity statins, addition of ezetimibe, PCSK9, for management for risk reduction purposes, not just LDL lowering, but also making it very clear that LDL is the primary target of therapy and lower is better in the highest risk groups. The most important change, though, is that the assessment of risk in both primary and secondary prevention in order to maximize the benefit to the patients, and also some changes in terms of the definition of lipid lowering efficacy. Is it 70 milligrams per deciliter, i.e. 1.8, or in the European guidelines, 55 milligrams per deciliter, which is 1.4. Now, the other thing is the scoring systems. So the scoring systems are a little bit tricky. So in a patient who's not symptomatic, has not had an event, is not diabetic, you're supposed to use these scoring systems to calculate their 10-year cardiovascular risk. Now, there's actually a difference between the European guidelines and the American guidelines, and it's this word here. The European guidelines only estimate fatal cardiovascular disease, fatal cardiovascular death. The American guidelines actually look at heart attack, stroke, or MI. So it's fatal and non-fatal. So the range is completely different, and this is a much more late presentation. Hopefully, you're likely to prevent more deaths by intervening with the patient before they have their first heart attack than waiting for them to die. So it's a very important distinction, and this is why the percentages are totally different. So here, in red is a risk of 10% of 10 years of fatal cardiovascular events. Here, the cutoff point is actually 7.5% in terms of heart attack, stroke, or fatal MI. So I think it's very important to make that differentiation, right? Because when you're describing something to the patient, you have to know what these numbers mean. Secondly, they look at conventional risk factors, which is what? Blood pressure, male or female, smoker and non-smoker, and of course, cholesterol. Now, the Europeans use total cholesterol, the Americans use total cholesterol HDL, which basically gives you the ratio, and the two blood pressures as well. In addition, they consider the presence of diabetes, hypertension, and smoking. It's a little bit more granular, and I think it gives you more detail. Also, ethnicity is mentioned in some limited sense. Now, what's the problem with this? The problem is if you apply these cardiovascular risk scores in the Middle East, systematically, we have found that it underestimates risk. It'll tell you that the patient is medium risk when they're very high risk. It'll tell you when the patient is low risk when they're actually intermediate or high risk. Why? Because these were derived from cohorts that are over the age of 40. In fact, this calculator will not work if your age put in is less than 40. Now, Dr. Nosheen mentioned this. I think the age of onset of myocardial infarction in the UAE is in the 40s. That means by the time they're 30, 39, or 40, they already have established atherosclerosis. So I think this is a really tricky point. And this is, excuse me, Dr. Wael's paper, which looked at a validated cohort from the UAE, from Sheikh Khalifa Medical City, and it's called the Salama database, and it tells you something remarkable. If you take all of the international risk scores, so the pooled risk equation, the American one, Framingham, and the WHO, unfortunately, the correlation between actual risk and calculated risk is only 0.55. That means that there is almost just a random toss of the coin. It does not tell you if the WHO or the ACC score is low, that the patient is actually low. In fact, it systematically underestimates risk because of the young age of the population and unfortunately the high burden of multiple atherosclerotic risk factors in the young population. So I don't think these are tests that we should use to deny treatment. I think they should be very careful. If you use this, there are a lot of fallacies in this, and maybe risk enhancers are the better way. Now, in terms of local guidelines, the Emirates Diabetes Society actually has published a very nice, recently updated guideline from February 2020, looking at the diabetic population. And this is actually their summary of terms risk categorization. So their suggestion, at least in the diabetic patients, if they have type 2 diabetes with cardiovascular disease, a prior MI, stroke, heart attack, or atherosclerosis in a vessel, in the neck, in the abdomen, or in the legs, then they are very high risk. If they are type 2 diabetic with target organ damage, so they have hypertension, dyslipidemia, LVH, microalbuminuria, retinopathy, neuropathy, very high risk. On the other hand, if they don't have established findings, look at this, if they have a duration of type 2 diabetes more than 10 years, and they have even one risk factor or even nothing else, you consider them high risk. This is a very important point. And if it's type 2 diabetes more than 10 years with two risk factors, in other words, diabetes and hypertension or diabetes and dyslipidemia, which is very common, automatically very high risk. So you're going to see that almost all diabetics are going to fall into a high-risk group, and very, very few of them are going to be low risk. The majority are moderate, high risk, or very high risk. So really, any diabetic patient benefits from a lot of intensification and particularly optimization of statin therapy. And in fact, if you look at the categorization of very high risk, a patient who has diabetes and a heart attack has the highest possible risk. It's called the extreme risk category, 40% of fatal or non-fatal events within the next 5 years. So are we actually complying with our own or even the international guidelines? So again, I refer to this important paper from the DICES Middle East study, which again, one of the principal investigators was Dr. Wael. So they looked at the patients with very high risk of cardiovascular complications using the scoring system, more than 10% fatal events. Because obesity and metabolic syndrome and diabetes was highly prevalent in these populations, what did we find? Dyslipidemia was 85% of those patients. 61% of patients at high risk do not attain their goal LDL, and that's based on the older guidelines. In fact, they also had an additional problem, which Dr. Noshin showed very nicely in the Dubai hospital registry. Low HDL and high triglycerides were found in the majority of patients. So they have the double hit, poorly controlled LDL and atherogenic dyslipidemia. And this is the very sad portion of this story, and I wanted to show you this in particular, is that 77% of patients in the CIFIA study remained on the same dose of statin since it was first prescribed. And we know that that's wrong. You have to optimize the statin dose because in every guideline, you need to reach now a target LDL of at least 70. And in the European guidelines, a 50% reduction on top of that. And you're not going to be able to achieve that unless you use a high potency statin, because a high potency statin is defined as a statin that lowers your LDL by 50%. So unfortunately, the statin dose potency, even in the high risk patients or the very high risk patients, was never maximized, and therefore lipid lowering was not achieved. In the DICES patients, 34% of very high risk patients were on high intensity statin, and a quarter of the patients were receiving lipid lowering therapy in additional lipid lowering therapy. So we have a lot of work to do, and it has to start with the baseline therapies. So what are the needs that we have to have? Efficacy of LDL lowering, achieving the goals, also working in the total lipid profile, and also safety and tolerability and adherence. So what are we doing with LDL lowering? How is it efficacious? How is it efficacious, and what do we do to treat that? So we've said this many times. Whatever study you look at, And whatever statin is used, any 1 millimole reduction of LDL is a 20% reduction of coronary artery disease risk, and that's fatal or non-fatal MI. This is the drop by 1 millimole here. So why do we not attain the LDL targets in the majority of patients? I mean, we're very fortunate in the UAE that this country has every treatment. All the statins are available. They're also available in very well-produced generics at very reasonable cost. So what's the problem? The problem is phenomenon of using low-potency statins. Why is that? There is no data for low-potency statins. All of the data was for high potency with a specific number to achieve. Number two, lifestyle modification. Very rare. People don't do any exercise here. You know, if you go to any street or any mall, there's not people running. The guidelines have changed, making it difficult for clinicians to know what's going on. Obviously, there's patient compliance, but as physicians, we can actually tell the patients what the compliance has to be and why there's a benefit. There's poor follow-up and monitoring of therapy, as you saw from the Dubai study and also our own registries in various different centers in the UAE. The frequency of LDL follow-up is not good. Now, underdiagnosis due to inappropriate use of risk calculators, which we discussed. And lastly, statin intolerance. So statin intolerance really is a phenomenon that you only see in about 10% of patients. And it doesn't mean the patient is not completely able to take a statin. Sometimes you can shift to another statin. Sometimes you can use supplementation or low dose. You really have to consider this as a disease, not just something, okay, I'm not going to give the statin. So which patients have we seen from the old and the new guidelines that benefit from high potency statin and aggressive lipid lowering, which may be in combination? Those are the highest risk patients. So basically all diabetes patients, as I mentioned, all patients with metabolic syndrome, patients with coronary artery disease of any kind, patients with familial hyperlipidemia, and of course, this is often forgotten. Chronic kidney disease is a direct marker of cardiovascular risk, and they're directly considered by the guidelines as high cardiovascular risk patients. Plus, of course, patients with severe hypercholesterolemia that may not be familial. Now, the definition of lipid lowering is describing the actual statin being used. Isn't that right? So, in the ESC guidelines, it's very clear that you can call a statin a high-intensity statin, high-potency statin, if it reduces the LDL by an average of 50%. So this means it's atorvastatin 40 and 80 and rosuvastatin 20 and 40. Anything less than that brings you to the 40%. So between 30 and 50%, right, what do we have? We have the lower doses of atorvastatin and the lower doses of rosuvastatin, plus most doses of Simva. Prava is fairly weak. It doesn't even get to 30% most of the time. And I think this is important. The definition of 50% reduction is what the guideline requires as the first step. You have to at least get 50% reduction. And in order to do that, on average, you have to use atorva 40 or 80 and rosuva 20 or 40. And with the rosuva 40, you tend to get a slightly better take-up, with the average is about 57%. Now, why do we have this objection to aggressive LDL lowering? So this is a really important study that was done by the group in Mount Sinai, Valentin Fuster's group. And if you find patients who did not have chest pain, they did testing to look for atherosclerosis, subclinical atherosclerosis, without additional risk factors, only hypercholesterolemia. In these patients, can you believe that patients with an LDL of 60 to 70, 11% of them had measurable atherosclerosis in the coronaries or in the carotids? And in patients with an LDL of 100, almost 30% of them had measurable atherosclerosis. The only people who did not have atherosclerosis in this cross-sectional population study was patients with an LDL between 50 and 60. So you realize right now that the average LDL in the population, and this is from the US, is 137. The average LDL in patients with a heart attack is 104. The only way to avoid having a heart attack, therefore, is to bring this number down by 50%. And by doing that, you need to use a high potency statin. So therefore, if you see a patient with an LDL of 105, it's not normal because it's leading to MI in almost 50% more patients, and it certainly needs to be lowered by at least 50% for patient protection before events and certainly after they've had a heart attack. And I hope this point is very clear from this epidemiology. So again, the frightening fact is if you see patients admitted with an acute coronary syndrome, and this is from the US, a large database from the US Veterans Administration, 136,000 patients admitted with a heart attack actually had an LDL of about 104, and an LDL of 70 was only seen in 17% of those patients. That's here. And this name here, this is Tim Russert. He's a very famous TV news anchor at NBC who had a massive heart attack. Actually, he was on TV when he had this heart attack with an LDL of 70. So really, we have a lot of inertia when we see these numbers, and we should never negotiate this idea. Lower is extremely better, and we're talking about heart attacks and strokes, and we need to try and achieve 50%. And the definition of 50% is embedded into the medication. At least 20% of 20 milligrams of rosuvastatin, 40 milligrams is even better, or alternatively 40 of atorva or 80 of atorva. So 50% reduction minimum to prevent 50% myocardial infarctions. So we actually have to summarize this and go back to this fact. The evidence-based medicine has proven that certainly over the last few decades that there's a direct linear relationship between lower LDL, lower risk of CV death, MI, and stroke. In addition, lower is absolutely, certainly, and definitively better. There's absolutely no bargaining this point. Combination lipid lowering therapy may be the only way to suppress LDL to achieve less than 55, but high potency statin is defined as a 50% reduction, and you have to start with that at least. 50% reduction is defined by rosuvastatin 40 or rosuvastatin 20, or atorvastatin 40 and 80. So, a question comes up, and this is something patients will tell you, and as physicians, sometimes we get this anxiety. Is lower and much lower safer? In fact, the answer is yes. It is in fact showing you additional and very robust benefits in much lower ASCVD events. So this was an article published by Professor Cocheret, who's the current president of the European Atherosclerosis Society, and this was published actually in the London Times. Lowering LDL to levels of a newborn baby cuts heart attack risk. And this is from 2016. What is the LDL level in a newborn baby? Does anyone know? It's 40 milligrams per deciliter or 0.75 millimoles, right? So lower is definitely safer. Not only that, you actually have more benefit. So what about this concern about very low LDL? So in the last 7 to 8 years, we've had more powerful studies that added medications on top of the baseline standard, high potency statin. And they looked at those patients who had a very low LDL, and this is from IMPROVE-IT, but we have it in the PCSK9 studies. So patients with an LDL less than 30 in this cartoon are in green. No significant difference in myalgia compared to patients with LDL of more than 70. No difference in adverse events leading to discontinuation or gallbladder or neurocognitive events. In fact, they were a little bit less with the green. No increase in stroke, no increase in hospitalization for heart failure, CV death, or cancer. So very, very low, less than the newborn baby, is very safe. And the average LDLs of 30 to 50, again, no difference between an LDL of 70 achieved or an LDL of 30. No difference in safety outcomes. So what are we waiting for? So what about earlier? Obviously, we've mentioned patients with familial hyperlipidemia. So this is a patient who starts to have a high cholesterol at the age of 7, 8, 9, or 10. Look at this. The LDL is also very high. It's over 4. This patient has a lot of exposure to LDL over time, and their likelihood of having a heart attack is much earlier. Now, what about the conventional patient who starts to become obese by the time they're married, 37, they now have an LDL of 3. Again, this is exposure over time. So, very important. Earlier is also better. Time is running out while we have inertia, and it invades our clinical practice. Now, there is no clinical study that tells you gradually up-titrate the statins over time. This is completely wrong. You don't give 10, wait 3 months, then go to 20, wait 3 months. That doesn't exist. You know the patient needs a 50% reduction. You give them the medicine that gives you 50% reduction, right? That's like a patient coming into the hospital with diabetic ketoacidosis and a sugar of 500, or 600, and you're going to give them 1 milligram of insulin. You don't do that. You treat it to lower the requirement immediately. So this is not evidence-based. It's not in any guidelines. And because these medications are safe and effective, there is no dose-dependent side effect that you're going to prevent. So you need to start the appropriate dose and or the appropriate combination immediately, and then reassess in 4 to 6 weeks. If that's not the case, then you add the second-line agent. So again, this is time running out for our patients talking about cardiovascular risk, while we allow years of LDL to accumulate and years of CV risk to accumulate. Early detection, which is easy, all we're doing is measuring LDL, and treatment is critical. Time is what we want most, but we are using it very badly. And again, time is running out while people debate targets and thresholds and side effects in spite of a lethal ASCVD progressive disease that can be primarily prevented with basic things such as lipid lowering, obesity management, and smoking cessation. And with that, I think we're on time to stop and take some questions. And thank you very much for your time and your attention.
Thank you very much, Hani. Please put your questions on the web chat. I don't have very many questions here. I will start. Dr. Nasheen, how has the pandemic affected the treatment of patients with hyperlipidemia in your practice?
Yes. Actually, although pandemic is about infectious disease, it's actually proven that cardiovascular disease and in general non-communicable disease, how important they are. Because we learned that there is a direct interaction between COVID-19 and cardiovascular disease. For example, COVID-19 can manifest or can affect cardiovascular disease with the form of arrhythmia, acute coronary syndrome, heart failure, myocarditis. The treatment of the overall treatment of cardiovascular disease and non-communicable disease have been affected by the pandemic in several ways. For example, patients, they are hesitant to come and seek medical advice. Patients don't know where to go because a lot of clinics and hospitals have been closed in order to receive COVID cases, or patients, they have lost their jobs and they don't have the financial ability to come and visit hospitals or to take their medications. And even from doctors' point of view, the hospital system, the health system have put the priority in the management of COVID-19 compared to budget, which is usually assigned for cardiovascular disease and non-communicable disease, and we are less accessible for patients. So overall, I always say with all the measures that all governments have done for the management of COVID-19, yes, we will have less mortality from COVID-19, but overall mortality will increase because we are neglecting the non-communicable disease and cardiovascular disease big time.
Yeah, very important point. Hani, I have some questions here.
Sure.
Somebody asks about the use of calcium score for coronary artery disease patients.
Absolutely. So if a patient has established coronary artery disease, there's really no point in doing the calcium score, right? Because they have ASCVD and therefore they are the very high cardiovascular risk, and you have to treat them with the 50% reduction and 1.4. I think the calcium score, as you have taught us many times, is very useful in those patients where there's uncertainty about lipid lowering, right? It's very useful in this country because we have a lot of patients with underlying risk factors, family history, and some of them are young and they don't want to take a statin, right? So if your calcium score is over 100, you have established ASCVD, khalas, you are literally like a coronary artery disease patient. On the other hand, though, if it's between 1 and 99, it still stratifies you into a higher risk group. So if your calculation is giving you low risk, you add the calcium score, which is the MESA score, which you've utilized a lot, Dr. Well, then the patient actually becomes a high-risk patient. So it stratifies immediately, and this is a patient you're going to tell them, look, this is the guideline, you have to take a statin. The other benefit of the calcium score, as you and I have done a lot of times, I'm sure Dr. Rasheen, you show the patient a picture of their heart and their arteries. There's calcium in your arteries, man. You have atherosclerosis. What are you waiting for? Do you want to get a heart attack? So it's a very powerful psychological tool when we're talking to the patients. So the guidelines recommend its use in patients in whom the risk is not certain. There are other risk enhancers. It is not useful in in smokers. You cannot use it in smokers to exclude statins. Statins, by definition, are required in smokers because they're automatically very high risk. So if a smoker comes to you and says, I want to do my calcium score, it's 0. No. You need a statin. It's not applicable in smokers.
Also on the same lines from the same physician, does the plaque burden affect your judgment?
Indeed, it does. Obviously, we have, if you have plaque and you have recurrent events, the National Lipid Association has published their own guideline. It's a little bit more complicated, but if you have extensive atherosclerosis in more than one vascular bed, so cardiac and carotid, cardiac and vascular, this is a patient which is extreme high risk. This is the 40% 5-year risk. And this is a patient that we need to quickly get on combination therapy. So I'm going to accept nothing less than 1.4 milligrams per deciliter. I'm going to check their lipoprotein A, try to lower that. This is a patient we're going to push maybe to put them on high-intensity statin, ezetimibe, and PCSK9 inhibitor. Particularly also the patient who has a recurrent cardiovascular event, a second event on a statin. This is a patient who needs an LDL of 1.0. This is an incredible number, 40. So we shouldn't back up from this. This is the only thing we know that can reverse remodel and improve cardiovascular events.
Yeah, sorry, can I? Apart from the smoker that you mentioned, Dr. Hani, I have noticed that a lot of our colleagues, if a patient is diabetic, they definitely include a statin in the medications. But if the patient is hypertensive, they have hesitation. They don't look at hypertension as another major risk factor for cardiovascular disease, whereas all hypertensive patients should have lipid control. This is one. The second thing, I'm sure you face a lot of patients who come with acute coronary syndrome, and then when you ask them about their cholesterol, or you ask them to start and continue a statin, they say, but doctor, my cholesterol is normal. So we don't know how normal it is, but what I always tell them, and it usually works on them, I say, whatever cholesterol you have in your body was enough to produce acute coronary syndrome and the cardiac event. So that also is another barrier because they go to one clinic and say, oh, your cholesterol is normal, so no need to take any statin.
It's an outstanding point, and if I can just take a point from you.
Can I ask you on that point, actually?
Yes.
Yes. Because I wasn't clear about this myself in the guideline. We talk about 50% reduction or the LDL target of 55.
And yeah.
So let's say if a patient comes to you de novo with an MI and his LDL is less than 55, do you still go for the 50% reduction? Is that what the guideline is saying?
So I think if we read the text properly and exactly what Dr. Rasheen said, if you have an event with whatever value, you need to drop that by 50% to gain that 20% reduction in event rate. So in fact, the dual recommendation is the 50% and 55 is to encompass the patients at the higher end as well as the patients at the lower end. So let me give an example. So if a patient comes in with an MI with an LDL of 100, obviously that didn't prevent their MI. So you need to drive that by 50% of 100, which is 50, which is automatically less than 55, right? On the higher end, let's say an FH patient comes in with an MI and an LDL of 200. If you give 50% of that, it's only 100, not 55. So then you need the additional 45 points to be reduced. So it's really important to do the math and expect that you need to have a 50% lowering of LDL, because that was the summary of the TNT study. It is the 50% reduction that actually leads to the 20% risk equation. So it's complicated, but I think we have to bear this in mind. And the Europeans have made it very straightforward, both.
Oh, but if your LDL is already at 55, do you go for another 50%?
Why not? Why not? It's 50%. It's still less than 55, but it's not protective. So I have a patient, actually, I think we've discussed this one before. Young guy, fairly fit military officer, massive inferior wall MI. LDL was 73 a week before at Imperial Diabetes Center on a high-intensity statin, right? We had a huge argument with the insurance that he needed to be on PCSK9 inhibitor, right? He needed to get to less than 30. It's as simple as that. And finally, they relented. And the fact is, at this guy, at his age, he also had a 70% stenosis in his LAD that was not ruptured. So this is an FH patient. I know this is an extreme example, and his lipoprotein A was over 400, but I think we cannot relent on the two values, right?
If you have a patient with mixed hyperlipidemia, high LDL, high triglyceride, what's your approach?
First, treat with statins. Actually, the guidelines said this very clearly in the triglyceride section of the lipids. So your first objective is to lower the LDL. There's a lot of ApoB particles in the triglycerides. Most high-potency statins will also have a significant effect on triglycerides as well and raise the HDL. We know this from the rosuvastatin data. And you first reach the LDL target. Once you hit the LDL target, then you start looking at residual risk and non-HDLC, right? So this is a misunderstanding. Some people don't realize that. Now, the opposite is true if a patient has severe hypertriglyceridemia. So somebody who comes in with pancreatitis and a triglyceride of 5,000, that's a different story, right? That's a different kind. It's familial hypertriglyceridemia or chylomicron syndrome. Dr. Wahid, can I just mention something that you taught us a long time ago? One of the big inertias in lab value is what Dr. Noshin mentioned. In the printout for the lab, they have what they call lab normal values. And those are just nonsense. They actually mean nothing, right? They're literally the median in the general population. And what you...
updated also.
Yeah,
not
exactly. Yeah, it's complete wrong. And that's what the patient comes back and says it's normal. So I think just to give a lot of credit to this information, right now, based on your work and also Dr. Layla, the lab values in our center do not say normal. They give you the recommended LDL for a high cardiovascular risk, very high cardiovascular risk. So we've actually incorporated the lab value and the accepted value for a high-risk patient. So it's making people think about risk and not think about normal values.
Yeah, I mean, we've talked about this many times, but I'll ask you, I mean, there's a lot of people out there who are anti-vaccine, some of them physicians, and the same group of people are also anti-statins. How do you convince these patients?
Okay, that's actually a very reasonable point because we also have to be realistic. In 2021, a lot of patients get their information from Dr. Google, isn't that right? So one of them is that slide that we showed with the linear reduction. I mean, the most intelligent or even the least intelligent or unread patient is going to understand this number. Number two, the use of, I'm not looking at your LDL just as a number. I'm telling you that I don't care if you lower it by bariatric surgery. I don't care if you use vinegar and salt. I don't care if you use a high-intensity statin. I want you to get this number down to 55 within a month and a half. So then the next question is, I'm going to diet and lose weight. So they all say that. Then we have data from Look Ahead, Direct, and other weight loss studies, and you can tell them, fantastic. You can do that. You're going to get a maximum of 10% weight loss is going to give you 10 milligrams, not even 30, of LDL reduction. So you can do that. I'm happy that you do it. I want you to do it. I want you to exercise. But within a month, I need you to come down to 55. Are you going to get down to 55? And then the number starts to click. So in the primary prevention patient, it is difficult, right? They haven't had an event. It's a theoretical concern. In the secondary prevention patient, we jump on this. You can't have another heart attack. You got to stop this. You got to do this. So not every patient gets convinced, but I think making it relevant to the patient and having a more lengthy discussion. I mean, I know that Dr. Noshin does this. I know you do this. I do it. We spend more time convincing patients to get on statins than to convince them to have a cath. Isn't that right? You know this. We've done it. We go into the room, 30 minutes later, the nurse is knocking on the door. She wants you to get out. No, I need to convince this patient. It's important.
I think, Dr. Weil, if I, for the primary prevention, how I convince my patients with statin, I tell them nothing can save you from having heart attack, no aspirin, no other medication other than lifestyle modification and stopping of the tobacco, plus only one medicine which has shown to be beneficial in primary prevention, and that is a statin. For secondary prevention, I think our job is a little bit easier because they already had the event, and definitely they can be warned about the recurrence of the event if LDL is not controlled.
One question here: what age do you recommend to start measuring cholesterol?
So actually it's interesting because the guidelines that came from the Middle East, dyslipidemia consensus, and the Emirates Diabetes Society are recommending earlier screening because of the high risk of atherosclerosis. So I would say that 30 is pretty reasonable in this population. We don't have any evidence-based medicine, but it's a strong recommendation, because if the first MI happens at 49, and it takes about 10 years to develop atherosclerosis, then I think if you start screening and therefore treatment at 30, that's also reasonable. The diabetes, actually, they are screening for diabetes at 30, so I think adding lipids, I don't know what you and Dr. Nosheen would recommend on a population level.
Yeah, absolutely right. We don't have data, but it would be important to start measuring early. One thing that caught my eye with the diabetic, Emirates diabetic guideline was the diabetes more than 10 years. I think in other guidelines it's more than 20 years, correct?
So the 10 years here is, so 20 years actually for type 1 diabetes. So the European Society of Cardiology is also using 10 years as the cutoff point for high risk. Can I just go back to the slide because I didn't memorize it? Just excuse me for 1 second. Yeah. So if it's less than 10 years and you have 2 risk factors, you're still high risk.
Right.
If it's more than 10 years, you're automatically high risk. And if you have diabetes and 2 risk factors, so essentially the 10-year cutoff point is making all diabetic patients fall into a high risk group, except if they have 1 risk factor or nothing, right? So accounting for this also is the age. Now the European
is the European the same as this? Is it 10 years in the European?
They don't stratify by age. They only take 10 years or less. The 20-year risk is actually for type 1 diabetes. Type 1 diabetes is 20
type 1 is the 20-year risk. Okay, yes. That's where is my confusion. Okay.
Yep.
Okay. Good. Any other comments?
So, well, I think you systematically looked at this in 2 big clinical studies, Cepheus Gulf and the DISIS ME. Have you noticed that there's an improvement in the uptake, or is it just because we're failing to meet targets almost the same percentage, or is it just the change in the guidelines?
Yeah, that's a very good question. We did this project like 3 times already, and well, remember that the target levels have dropped.
Yes.
Yeah, so you can't really compare. You can't compare but I think in general one can safely say that very little movement has happened between Cepheus, DISIS, and the last one. I can't remember what the last one was called, but we did another one. We did another one after DISIS.
Okay.
And it was also published, and that showed very similar data, just basic inertia, no movement, particularly in the high-risk patients.
High-risk patients, yeah. That's terrible.
I think, as you mentioned, once a patient is stuck on a medication at a certain dose, physicians just don't bother, whether it's a blood pressure pill or a sugar pill, or, there's a lot of it's not just in lipids.
Okay. And I think the point is that's why we have to start the right dose at the beginning. That's what we do, with heart failure patients. The earlier you initiate, you maximize. It's the same thing with statins, only there's the evidence for statins is that you should use the highest dose from the beginning. Unless the patient doesn't tolerate it.
We have a doctor here talking about pleiotropic effects. I think you can answer that one.
Yeah. So statins and lipid lowering in general seem to have differential effects from non-statin. So it's pretty clear that the monotherapy with ezetimibe didn't actually have any impact on cardiovascular events. On the other hand, PCSK9 inhibitors and combination therapy with statins, so ezetimibe with the statin, did in the IMPROVE-IT study show reduction of atherosclerotic events, reduction of inflammation. We have the famous studies from Jupiter that the C-reactive protein was reduced, of course, with the rosuvastatin at high dose. So I think it is important to realize that the cornerstone of therapy is always going to be statins. Any attempt to bypass statins is kind of risky because the evidence on statins is so incredible and so robust, and it's the standard of care. And like, Dr. Nosheen and yourself have mentioned, it's a very cheap and effective therapy. You can literally apply it at the population level, and we're going to bring the entire curve leftwards and reduce cardiovascular events. So it isn't just lipid lowering that it's being done here. There's an anti-inflammatory property, as we know from the CRP, and the alternative therapies just don't have the evidence base for monotherapy. Now, in patients who are statin intolerant, we have to use monotherapy, right? We have to give them PCSK9 without a statin. They're truly statin intolerant. So we have to test the statin intolerance pathway, do all of the things that are required before we decide to go on a path of just one medication.
Excellent. I think with that, I will come to an end. I'd like to thank Dr. Nosheen and Dr. Hani for excellent presentations. I'd like to thank Asino and ICOM for supporting this webinar today, and hope to see you soon. Thank you very much.
Thank you. Thank you, Dr.
Bye.